Hello and welcome. In this video, we will discuss laboratory testing for managing anemia in pregnant women. Red blood cells provide oxygen to the body tissues, and anemia is when the body does not have enough healthy red cells. Women of reproductive age are prone to anemia, and the OBGYN specialist is involved in the testing. Beyond a basic stage of testing, the specialist may refer the patient to a hematologist. Some patients may have underlying chronic medical conditions or developmental abnormalities requiring specialized hematological treatment. Even with nutritional anemia, the management will vary depending upon the gestational age at which the woman presents and the hemoglobin level. So before going on to talk about the laboratory testing, let us just quickly go through a brief overview of how iron is taken inside the blood and transported to the bone marrow. So the metabolism of iron in human blood is an important overall health and hemostasis aspect. Here's an overview of how iron metabolism works in the human body. Iron is primarily absorbed in the duodenum and the upper jejunum of the small intestine. Dietary iron exists in two forms: heme iron, which is found in animal products, and non-heme iron found in plant-based foods and supplements. Heme iron is more readily absorbed as compared to non-heme iron. Once absorbed, iron is transported into the bloodstream. So in this transportation, it is bound to transferrin, a protein that carries iron throughout the body. Iron that is not immediately needed for metabolic processes is stored in the form of ferritin and hemosiderin. Ferritin is present within the blood and hemosiderin is present in the tissues, for example, the liver. Iron is utilized by cells for various functions. One of the most critical functions is its incorporation into hemoglobin, the protein in the red blood cells responsible for transporting oxygen from the lungs to the tissues throughout the body. Iron is also a component of myoglobin, which stores oxygen in muscle cells, and various enzymes involved in energy metabolism and DNA synthesis. So iron metabolism is tightly regulated to maintain a balance between absorption, utilization, and storage. The body has limited mechanisms for iron excretion. Iron loss mainly occurs through the shedding of epithelial cells and menstruation, and in small amounts through sweat and urine. So maintaining a proper balance through dietary intake and regulation of absorption and storage is essential for overall health. So in this picture here, we see the non-heme or the vegetable component of iron and the animal component of iron being taken in as a diet, and when it reaches the jejunum, then it is absorbed into the bloodstream, and in the bloodstream it is transported through the transferrin molecule, and then it is either utilized taken to the bone marrow, and where it is utilized for the formation of red blood cells, or it is taken to the liver where it may be stored in the form of hemosiderin. So these red blood cells are vital for the circulation, for oxygenation, and for maintaining good health in human beings. Pregnant women and women who have gone through a lot of childbearing may have low levels of hemoglobin because they lack dietary supply of iron and they may not take supplementation, and at the same time they have a high output and high requirement because of loss through childbirth. The World Health Organization classification of anemia in pregnancy is defined as mild, moderate, or severe. The cut-off point for anemia is a hemoglobin of 11 grams per deciliter, and if the hemoglobin is between 9 grams to 10.9 grams, it is mild anemia, But if it is between 7 and 8.9 grams per deciliter, then it is considered as moderate anemia, whereas a level below 7 grams per deciliter is severe anemia. The etiological classification of anemia includes causes such as nutritional anemia, which results from deficiency in iron, vitamin B12, folate, hemolytic anemia, which is increased destruction of red cells due to intrinsic factors such as genetic disorders like sickle cell disease, or extrinsic factors such as autoimmune reactions or infections such as malaria. Bone marrow failure resulting from decreased production of red cell due to bone marrow disorders such as aplastic anemia or myelodysplastic syndromes. Other etiologies which contribute to the etiological classification of anemia includes anemia of chronic diseases, which is seen in autoimmune diseases, chronic inflammatory conditions, malignancies, in which there is impaired red blood cell production and disturbed iron metabolism. Renal anemia is due to decreased production of erythropoietin by the kidneys, often seen in chronic kidney disease, and hypoproliferative anemia due to inadequate production of red cells from the bone marrow, which can be caused by various factors, including nutritional deficiencies, bone marrow disorders, or chronic diseases. So apart from the etiological classification, which gives us a very important aspect of the causes of anemia, we can classify anemia in other ways. And so if you are going to give a classification of anemia, you should be conscious about what you are considering as the basis of the classification. So other classifications include a pathophysiological classification in which there is microcytic, normocytic, and macrocytic anemia, or a morphological classification depending upon what you actually see on your slide, the RBC, they may be normochromic or hypochromic. And clinical classification, like for example, asymptomatic or symptomatic anemia, and severity classification, for example, mild, moderate, or severe anemia. Now we talk about the laboratory tests for the different types, the severity, and the causes of anemia. So these tests, along with clinical evaluation and history taking, play a crucial role in diagnosing and managing different types of anemia effectively. So this is important to understand that not all types of anemia will be diagnosed easily or be treatable by the gynecologist, and therefore in the first instance, when you start the process of testing, you may find a result for which you will then have to refer the patient to a hematologist. The interpretation should be done in conjunction with clinical findings and other relevant investigations for accurate diagnosis and appropriate management. So the most basic test which is done for anemia is a complete blood count. In this test, we check to see the different parameters of the RBCs, the WBCs, and the platelets. As far as the RBC is concerned, we check the hemoglobin level, the amount of hemoglobin in the blood, plus the hematocrit, and there's a consistent ratio between hemoglobin and hematocrit of 1:3. Hematocrit represents the percentage of blood volume occupied by the red blood cell, the red blood cell count, the number of red cells per volume of blood, the mean corpuscular volume, which is different in a nutritional or iron deficiency anemia as compared to megaloblastic anemia, the mean corpuscular hemoglobin or the average amount of hemoglobin in each red blood cell, and the mean corpuscular hemoglobin concentration, average concentration of hemoglobin in red blood cells. So in the complete blood count, what it tells us is that it tells us about different types of anemia, and all these parameters will be particularly useful in this regard. The interpretation involves comparing the values of these parameters with the reference ranges. For example, a low hemoglobin, hematocrit, and RBC count, along with specific mean cell volume and mean corpuscular hemoglobin values, can indicate different types of anemia, such as iron deficiency anemia, vitamin B12 deficiency anemia, or folate deficiency anemia. So along with the complete blood picture, the lab will always do a peripheral blood smear in which there is a microscopic examination of a stained blood smear slide to visualize the morphology of the blood cells. And this is a very important part of the complete blood picture, because it gives you an accurate picture of a visual picture of the red cells and the relationship with the white cells as well as any new kind of cells. It identifies abnormalities in red blood cell morphology such as microcytosis or macrocytosis or hypochromasia, or the presence of abnormal shapes like sickle cells. Interpretation involves assessing the size, shape, color, and distribution of the red cells as well as the presence of any abnormalities such as nucleated RBCs. The poikilocytes and the anisocytes are immature red cells, and so an increased proliferation of these will indicate anemia and rapid blood formation. This information aids in determining the underlying causes of anemia. The reticulocyte count are the immature red cells or the nucleated red cells. They are, if present in the bone marrow and released into the peripheral blood, and a small percentage, about 1%, will always be present in the blood, but they should not be in very large numbers. So in the peripheral blood, these nucleated reticulocytes will mature within 1 to 2 days, and the count is typically reported as a percentage of the total number of reticular blood cells. So if the reticulocyte count will indicate the bone marrow's response to anemia. A low count may suggest decreased red cell production, while a high count may indicate increased production in response to blood loss or hemolysis. So the interpretation involves comparing the count to reference ranges, and generally after blood transfusions, the reticulocyte count may be suppressed, because if there is enough hemoglobin and enough iron in the blood, then the bone marrow will be suppressed and will not rapidly form red cells. But in an anemic patient, the reticulocyte count may be slightly increased if there is enough hemoglobin, if there is enough iron in the circulation. Sometimes you can rarely see inclusions, and this is not something that can be interpreted by a gynecologist, and for this you need to refer the patient to a hematologist, because this means that there are certain inclusion bodies which are very specific and which have specific clinical application, clinical understanding. It may even be due to lead poisoning or due to thalassemia, or it may be in G6PD deficiency. Lab studies which tell you about the level of iron in the blood are very crucial and very critical, because they tell you how to give the iron to the patient, first of all, and secondly, and with what rapidity, whether you need to give blood or not. And so these studies include serum transferrin saturation. So serum transferrin saturation is calculated as a ratio of serum iron to total iron binding capacity, and it indicates percentage of transferrin saturation with iron. So for example, if the serum transferrin saturation is low, this is an indication that the amount of iron that is available in the blood is very low, and the total iron binding capacity will be very high. So it's a ratio between the serum iron level and the total iron binding capacity. Ferritin level, so as we have explained, ferritin is a protein, and it binds with the iron, and that is how it circulates in the peripheral blood as ferritin. So the ferritin level will measure the body's iron stores within the circulation. And so if the ferritin levels are low, it is an indication that there is a level of anemia which is related to iron deficiency. Serum iron level also measures the amount of iron circulating in the blood, whereas total iron binding capacity is the blood's capacity as transferrin to bind and transport iron. So in a way, transferrin levels and serum total iron binding capacity are related to each other, because they are measuring the same thing, that is, they are measuring the amount of iron which is bound to transferrin. However, ferritin levels are more important as they measure the iron stores within the blood circulation. So iron studies measure various parameters related to iron metabolism, including serum iron, total iron binding capacity, transferrin saturation, and ferritin. Iron studies help in diagnosing iron deficiency anemia, anemia of chronic diseases, and other iron metabolism. So interpretation will involve assessing the levels of serum iron, etc. In iron deficiency anemia, the serum iron and ferritin levels are typically low, while total iron binding capacity and transferrin saturations are high. One may get a bit confused between serum ferritin and iron levels, and to explain this, you must understand that ferritin is a protein that stores iron and releases it when the body needs it, whereas serum iron is a mineral which is present in the red cell. So serum iron and ferritin work together, but they are not the same thing. One is a mineral and the other one is a protein. Serum iron is more relevant to understand the need of the body for supplementation of iron stores. It is possible to have a normal hemoglobin level, but low levels of serum ferritin. And this is seen when there is chronic inflammation, certain diseases such as, or even a diet lacking in iron-rich foods. In some cases, it could indicate iron deficiency in the early stages before it affects the overall iron levels in the blood. And normal iron levels but low serum ferritin levels will indicate that your body is not effectively storing iron, and there are diseases in which this happens. Times when the peripheral blood film is showing a lot of abnormal cells and the red cell count, the white cell counts, and the platelets are highly abnormal, the patient might need a very thorough investigation by looking at the site where the red cell production is taking place. And this is known as either bone marrow aspiration, where some fluid is aspirated from the bone marrow, or a biopsy, where a biopsy is actually taken from the bone marrow. So this provides information about the cellular composition and function of the bone marrow, aiding in the diagnosis of certain types of anemia, such as aplastic anemia or myelodysplastic syndromes. These tests, along with clinical evaluation and history taking, help in diagnosing and managing various types of anemia effectively. The choice of the test may vary depending on the suspected cause of the anemia and the patient's clinical presentation. In such cases, a hematologist or sometimes even an oncologist will be involved in the care of the patient, and this is not the domain of the gynecologist. Hemoglobin electrophoresis is a very important part of testing of the blood in cases of anemia, because this looks for abnormal types of hemoglobin and measures the types of hemoglobin levels. So, for example, adults have a preponderance of hemoglobin A or adult hemoglobin, and there is a small percentage of 2% or 3% of hemoglobin A2, which is also a type of adult hemoglobin. But hemoglobin F is present only in the fetus, and once the fetus is born, then this is replaced by hemoglobin A and hemoglobin A2. And hemoglobin E is also normally absent. So if the hemoglobin type is abnormal, it is a sign of a hemoglobin disorder and is used for diagnosing anemia, sickle cell disease, thalassemia, and other hemoglobin disorders. So hemoglobin electrophoresis will identify abnormal hemoglobin variants such as hemoglobin S or hemoglobin C. This is a laboratory technique used to separate and identify the different types of hemoglobin, and it helps in diagnosing various hemoglobinopathies such as sickle cell disease, thalassemia, or hemoglobin variants. The interpretation involves analyzing the pattern of hemoglobin bands on the electrophoresis gel to identify abnormal hemoglobin variants or mutations associated with specific types of anemia. Of serum vitamin B12 and folate levels may not be interpreted easily by a gynecologist, and again for this you may need the help of a hematologist. Erythroplasts require folate and vitamin B12 for proliferation during their differentiation in the bone marrow. And deficiency of folate or vitamin B12 inhibits purine and thymidylate synthesis, impairing DNA synthesis and causing erythroblast apoptosis, resulting in ineffective erythropoiesis. So if the vitamin B12 and the folate deficiency occurs, then a lack of this causes the body to produce abnormally large red cells that can't function properly. Red blood cells carry oxygen around the body using hemoglobin, and these red cells with deficiency of vitamin B12 and folate will not be able to do this function. So the combination of high folate and low vitamin B12 in older adults could be the result of vitamin B12 malabsorption or non-resolution of deficiency even with supplementation, and hence the higher risk for negative health outcomes compared to those who have normal vitamin B12 but not high folate. There are 4 stages of vitamin B12 deficiency. In stage 1, there is decreased levels of vitamin B12 in the blood. In stage 2, there may be metabolic abnormalities. In stage 3, there may be some neurological or psychological symptoms such as anxiety, confusion, problems with balance and others. And stage 4 is macrocytic anemia, when very large blood cells are seen on the peripheral film. This test will measure the levels of vitamin B12 and folate in the blood, and it will tell you about the levels if they are low and their association with megaloblastic anemia. So again, this patient should be referred to a hematologist. A little more explanation about bone marrow and its testing. So the bone marrow is the red blood cell factory, and healthy bone marrow will release red cells into the bloodstream when they are mature and when required. Without bone marrow, our bodies could not produce the white cells we need to fight infection, the red cells we need to carry oxygen, and the platelets we need to stop bleeding. So this process is known as hemopoiesis, and in children, hemopoiesis takes place in the long bones like the femur, but in adults, it's mostly in the vertebra, the hips, the ribs, the skull, and the sternum. So a bone marrow aspiration, where some fluid is taken from inside the bone marrow, or a bone marrow biopsy, where a piece of tissue is taken, is then examined microscopically. And it can provide information about the composition of the bone marrow cells, which are contributing to the blood, to the maturation of these cells, the function of the bone marrow, and to aiding in the diagnosis of various types of anemia, such as aplastic anemia or myelodysplastic syndrome. So the interpretation is done in conjunction with clinical findings. The clinical evaluation and history taking plays a crucial role in diagnosing and managing the different types of anemia. And the other investigations may also be required for accurate diagnosis and appropriate management. So this diagnosis, this assessment, and even the ordering of this test is only done by the hematologist and not by the gynecologist. With this, we come to the end of the video. If you like the video, then please subscribe and support the channel. Press the bell icon to make sure that you are notified of future productions of the videos. Press the like button, share with colleagues and friends, and please send comments for feedback. Thank you and goodbye.